Hi, my name is Mickey and I'm going to be covering ventilation. First, let's start off with the objectives. And the first objective is going to be to define ventilation. Next objective is describing lung volumes and capacities. Third is describe the physiologic functions provided by ventilation. And then it's going to be describe the pressure gradients responsible for gas flow, diffusion, and lung inflation. And lastly is describe the factors, describe the forces that oppose gas movement in and out of the lungs. And so let's go ahead and describe ventilation first. So ventilation is a cycle that has two phases, inspiration and expiration. And during each cycle, a volume of gas is moving in and out of your lungs, and so that's what defines ventilation. And also ventilation also assists in providing oxygen to your lungs, and it also assists in removing carbon dioxide out of your lungs. And so you can see in the picture here, upon inspiration it's assisting in providing your lungs with oxygen, and then upon exhalation it's assisting in removing carbon dioxide out of your lungs upon via exhalation. And so there's lung volumes, there's different types of lung volumes, and it consists of an individual volume. The first volume is your tidal volume, and that could be defined as the volume of air inhaled or exhaled during each normal breathing. So right now, the normal breathing that we're doing, that's considered to be your tidal volume. And the tidal volume is what supplies your body with the oxygen and the removal of your carbon dioxide. And next is your inspiratory reserve volume. I'm sorry, going back to the tidal volume really quick, is your normal tidal volume is 450 milliliters. And also one thing to know about your tidal volume is that during, it changes during a time of rest and during exercise. Okay, so next is your inspiratory reserve volume, and that's the maximal volume of air that can be inhaled over and above the inspired tidal volume. So basically, when you're breathing in normally, there's still some room left in your lungs to go ahead and breathe in further. Okay, next is your expiratory reserve volume, and that's the maximal volume of air that can be exhaled after exhaling a normal tidal volume. So it's the opposite. So after you exhale out, there's still some reserved room for you to continue exhaling out. Okay, last is your residual volume, and this one is very important, and it's the volume remaining in the lungs after a maximal exhalation. So basically, without a residual volume, without that leftover air or volume of air inside your lungs could collapse. And so if your lungs collapse, then you could die. So it could be not good. So you need that residual volume. Next are your lung capacities, and that consists of one or more capacities. First one is your total lung capacity, and that's the total amount of gas in the lungs after maximal inspiration. And so basically, it's when you take in a deep breath, and it's the volume of gas that's left inside your lungs, which equals your total lung capacity. Your inspiratory capacity is the total amount of air you can breathe in starting at tidal expiration. And so a way to think about it is you're just going to breathe out normally, and then you're going to inhale in. And another way to remember is if you're going to go jump into the pool, what is it that you're going to do first? You're going to hold your breath, right? So you're going to take a deep breath in, and that's going to be your inspiratory capacity. Next is your functional residual capacity, and that's the amount of gas remaining in the lungs after a normal tidal expiration. And your functional residual capacity could make up to 40% of your total lung capacity. Next is your vital capacity, and that's the amount of gas that can be exhaled after maximal inspiration. And so it's when you take a deep breath, you take a deep breath in all the way, and then you blow it all out. And that's what equals your vital capacity. So you could also practice those, if that's going to help you remember which one is which. And so here you could see it on a graph. And here is your normal tidal volume. This is the way it looks. Again, it's the normal breathing that we're doing. And then your inspiratory reserve volume is right here. The amount that you could still breathe in after a normal breath. And then you're going to exhale it out. And that's going to be your expiratory reserve volume. And then it goes back to your normal tidal volume and so on and so forth. And right here is that residual volume that I told you about that is very important, that we need to have basically in order to stay alive. Okay, and so that's the way it is here. And then one thing to know is if you add your expiratory reserve volume and your residual volume, that's going to provide you with your functional residual capacity. Okay. Next. In order to be able to measure those volumes and those capacities that we just talked about, a test is going to be performed, and that's called a spirometry. And so it's a spirometry test, and what it is, it's a pulmonary function test that is used to determine different factors on how your lungs are functioning. And so what is the purpose? What's the purpose of performing this spirometry test? And so the purpose is that it's used for health surveillance programs. It helps establish the type and the degree of a pulmonary impairment. And a pulmonary impairment would be patients with COPD, restrictive lung disease, or upper airway obstruction. And then also it's the evaluation of lung status when reversible airway disease is suspected or present. And another purpose of the spirometry test is that it's used to determine if a patient's medication is helping. So, for example, a patient with asthma, we want to make sure that their medication is working. And so they could perform a spirometry test in order to help determine that. Okay. And so once this test is performed, what is it measuring? And so it's measuring the forced vital capacity, and that's the total volume of air that can be exhaled during a maximal forced expiration effort. And so the way that is you're going to take a deep breath in, and then you're going to exhale out until you can't exhale out any further. And so you get the picture. And then next is your forced expiratory volume in 1 second. And so what that is the volume of air exhaled in the first second after a maximal forced inhalation. And so you're going to take a deep breath in, and then you're going to exhale out as quick as you can in 1 second. And once you exhale out in that 1 second, it's about 60 to 70% of lung volume that is exhaled out in that 1 second. Other types of measurements also is other forced expiratory flows. And so, for example, it's a forced expiratory flow volume in 3 seconds, also one in 6 seconds, and then a peak expiratory flow. And also it measures a maximum voluntary ventilation. And so what that is a maximum amount of air a person can breathe over a specified period of time, which is usually 12 seconds. Okay. Next are there's going to be there's some pressure gradients, and you want to become familiar first with these terms. And so here are the definitions, and these are the terms, and you could just use your medical terminology to help break up the words so that you could have an idea of where it's happening. So over here it's the transrespiratory pressure. So trans across respiratory, okay, and transthoracic pressure, trans chest wall, pressure inside of the lungs, pressure between the parietal and visceral pleura, and the transpulmonary pressure. Okay, so you could just go ahead and take the time to go ahead and read that, the definitions for that. And so those are also, sorry, going back, these right here are physiological functions happening inside the lungs, part of the physiological functions happening inside the lung, okay? And so another part of a physiological function or changes happening has to also consist with your diaphragm and your thorax. And so what is happening what is happening to the lungs during inhalation. So I'm going to give you a couple of seconds so you could try to figure out the order of this on what's happening during inhalation or inspiration. Okay. So basically what I did is I already put it in order for you. And so the diaphragm contracts, the thoracic cavity expands, intrapleural pressure decreases, the lung expands, the alveolar pressure decreases, therefore air is now being able to flow into the lungs, and that's during inspiration. So what are the physiological functions happening during expiration? I'll give you a couple of seconds to look at things, try to put those in order so you could see what's happening during exhalation. Okay, and so during exhalation, what I did is I made it easy again. And basically it's going to be starting from the bottom, and you just work your way up. So the diaphragm relaxes, the thoracic size decreases, and both pleural pressure and alveolar pressure increase, and causing the lungs to deflate. Alrighty. So in order for all of these things to happen, a pressure gradient needs to be present. Without a pressure gradient, then the movement of gas and carbon dioxide inside and out of the lungs, into and out of the lungs and everything, it cannot happen without a pressure gradient, okay? And so during inspiration, the way a pressure gradient is developed or created is the diaphragm contracts, down, allowing the thorax to expand. When the thorax expands, it decreases the pleural pressure, causing a positive change in the transpulmonary and transairway pressure, leading to a drop in alveolar pressure. And so once all of that process happens, a pressure gradient is now developed for inspiration. Okay. And so one thing to keep in mind, which I'm going to discuss also right now in a bit, is at the beginning of inspiration, your alveolar opening pressure is always positive. Okay, and so the gas that you're going to inhale in is going to follow the pathway of least resistance, which again I'm going to explain in a bit. And then upon exhalation, the alveolar opening pressure is now negative. And again, so once the gas is inside of the lungs, it's going to want to follow in the pathway of least resistance, and it's going to want to come out on exhalation. Okay, which again I'm going to discuss in a bit, so just bear with me. So then the pressure gradient for exhalation is created when the opposite effect happens. And so what the opposite effect is that the thorax and the lungs want to recoil back to their original shape. The pressure inside the lungs then increases, allowing for pleural pressure to increase from, let's just say, like -10 to the normal -5. And I'll explain that in a bit. And in this process of the pleural pressure is happening because the thorax is wanting to come back down, and the diaphragm and the external intercostals want to return back to their normal shape. And so once all of this process happens, then that's what creates your pressure gradient for exhalation. And so, as I was mentioning right now in regards to the pleural pressure and the changes happening throughout for your during inhalation and exhalation. So first, during inhalation, the volume drops, and then it increases for expiration, as you can see right there. Your intrapleural pressure, your normal intrapleural pressure is always -5. And so when you inhale, it's going to decrease, therefore becoming more negative. And then upon exhalation, it's then going to become positive. From the right here is -8, so it's going to become positive back to the normal -5. And then the flow also is going to decrease upon inhalation, and upon exhalation, then the flow of the volume is going to now increase. Now, one thing to know is that during the alveolar pressure during normal resting period, it's always going to be it's at 0. It starts to become negative once you start to inhale. It becomes negative, and then when you exhale out, it's going to become positive until you're done exhaling. And then there's a time frame where there's no breathing or no exchange happening, and that's going to bring back your alveolar pressure back to the normal state of 0. Okay. And so when I was discussing earlier in regards to the airway opening, upon inhalation, the airway opening is always going to be positive, while your alveolar pressure is going to be negative. And so what it looks like is, here's a little picture, excuse my drawing here. And so consider this to be your airway opening, okay? And so these are all gas molecules. And so it's all accumulated here, and it's going to want to go in the pathway of least resistance and go into where there's more room to be able to move around, because right here they're just so crowded. And so you're going to breathe in, and all the gas molecules are going to go in to a negative pressure of the alveoli. So once you inhale in, then now you've inhaled and you've reached your max already. So then you're going to want to exhale out, right? So then the opposite effect happens, and now the alveolar pressure has now become positive, and the pathway of least resistance is now going to be in the opposite direction, and it's going to be that the gas molecules are going to want to go out into the atmospheric air, where that pressure is now negative. And so this is all through pressure gradients that all of this happens. So yeah. Okay. Now, one thing, another difference, pressure difference, is what's called a driving force. And so you could look at this as the release of built up energy. Okay. And so in our lungs, we have elastins. Okay. And then those we have elastins, And what that is when you inhale, your lungs expand, right? And so what your elastins are is it allows your lungs to recoil back to their original shape. Okay? And so um when the shape of your lungs change, the volume inside of of the lungs also changes. So for example, when you take a deep breath in, we're going to look at this as you taking in a deep breath. Okay? You take a deep breath in and you hold it. You're holding it right there. Okay? You're building up energy. The energy is being built up in your elastins, your lungs, and your chest wall. And so when you exhale, you're going to exhale out rapidly because of all that built up energy. And that's what creates your driving force. And so that could also be looked at as your elastins times your volume, which which equals your transpulmonary pressure. Okay. And one thing to keep in mind that is important to know is during exhalation, your exhalation is a passive process, and so it becomes active when you have to use your accessory muscles. And a time where you're going to be using your accessory muscles is during time of exercise. You use your accessory muscles, and so exhalation then becomes active. But other than that, during normal state, your exhalation is always going to be considered to be a passive process. And so, with all of the things going on in the lungs and everything, there's some forces that could oppose how your lungs function. But first, what we want to do is we want to become familiarized also with elasticity. So, elasticity is the physical tendency of an object to return to its initial state after deformation. And so that consists of your lung elastins plus the chest wall elastins. An example of your chest wall elastins consists of your skin and your rib cage and so on and so forth. And so how you could look at this is by comparing it to a rubber band. I'm gonna use a rubber band to compare it to your lungs. And so basically it's these the lungs expand during inspiration, so they're in expanding, and then once they have reached the complete inspiration, they're going to have a tendency to want to recoil or to come back, yes, recoil back to normal shape. And so the more that you stretch it out, the more the tendency it has to want to return back to its normal shape. And that's an example of elasticity. And so the the greater the inspiration, the greater elasticity tension that is created after a maximal inhalation. Um, and so part of the part of the elasticity, you have some elastic and collagen fibers that contribute to this. And so if you lose your elastic and your collagen fibers, then your lung is going to be able to stretch out, but it's not going to be able to return back to the original shape. And so that what that does, it creates some floppy, loose lungs. And this happens a lot with patients who have emphysema and COPD. They lose a lot of their elastic and collagen fibers, and so by them losing that, that creates them to increase their work of breathing. And so those are some forces that are opposing the inflation of the lungs that contribute to that. Alrighty, so now time for some questions. We'll see how much of this you paid attention to. First question is, what happens to the alveolar pressure during inspiration? Does it remain the same, B become positive, C become negative, or D it disappears? And the answer is C. It becomes negative during inspiration, because remember, during normal resting stage it's at 0, and when you start inhalation it goes to negative, becomes negative. Next is your next question is ventilation can be defined as the physiologic process of oxygen use at the cellular level. True or false? Oh, sorry, just kidding. True or false? And the answer is false, because ventilation is the process of removing gas in and out of the lungs. Your next question is, at the beginning of exhalation, the atmospheric pressure is positive relative to alveolar pressure. True or false? And if you answered false, you're correct. Because at the beginning of exhalation, it is negative because remember, gas travels in the pathway of least resistance. I'm sure you're getting all of these right so far. Question number 4. The tendency of the lungs wanting to return back to their original shape is known as, take a minute to look at this, and your answer that you chose should be C, elasticity. Okay. The last question is, what is required in order for gas to move in and out of the lungs? And the answer is pressure gradient, because I've been drilling that into your head already. So a pressure gradient is needed in order to move gas in and out of the lungs. Oh, yes. Okay. So that concludes this video. I hope you enjoyed, and I hope it was helpful. Thanks.